Welcome back to CLOT Conversations, the podcast from Thrombosis Canada, where we explore important new research, clinical guidance, and practical issues in thrombosis care. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm pleased to be joined by my co-host, Dr. Jamil Abdul-Rahman from Toronto General Hospital and Dr. Maha Othman from Queen's University in Kingston. Today, we're discussing the 2026 guideline for the evaluation and management of acute pulmonary embolism in adults. We're delighted to welcome two members of the writing committee, Dr. Lana Castellucci and Dr. Kerstin de Wit.
Our first guest is Dr. Lana Castellucci, Associate Professor at the University of Ottawa, Scientist at the Ottawa Hospital Research Institute, Vice President of Thrombosis Canada, an active CAN vector investigator, and holder of Tier 2 Research Chair in Thrombosis and Anticoagulation Safety. Her research focuses on venous thromboembolism, anticoagulant safety, and bleeding management. Joining her is Dr. Kerstin de Wit, who trained in internal medicine, emergency medicine, and thrombosis, completed a thrombosis fellowship in Ottawa, and now leads a research program focused on diagnosing bleeding and clotting disorders at the emergency department. She holds a Tier 1 Canada Research Chair in emergency venous thromboembolism. Thank you both for joining us today.
Thanks for having us.
Yeah, thank you.
Okay, so I'll get started with the first question. So what was the motivation to update the guidelines on the evaluation and management of acute PE in adults?
So I think from the AHA perspective, it had been many years since they had a guideline on pulmonary embolism. And so it was a very timely opportunity to bring together a very multidisciplinary group of experts. As you know, the European Society of Cardiology has their own set of guidelines, and their most recent edition is from 2019-2020. And so this was an opportunity for accumulating the evidence thus far since both of those guidelines from AHA and ESC, and bringing together some experts from across North America to put together a guideline that would be relevant not only in North America, but internationally as well.
And if I could add, I think it was particularly important to have an American guideline because there's so much practice variation, particularly in the acute setting, in the more severe cases of pulmonary embolism. So I think there was a wish among the experts to standardize practice. So to create some benchmarking in an area where the evidence is changing pretty rapidly.
Right. So the guidelines is comprehensive, and one of the key features is the new clinical categories and certainly the focus on acute PE. Could you please give us an overview of those clinical categories and why these were introduced?
I would be happy to give a broad overview. So the AHA guidelines chose to create a brand new set of clinical categories, which moves away from the previous nomenclature where we used to talk about low-risk pulmonary embolism, intermediate risk with the dual strategies of intermediate low and intermediate high, and high risk. And the AHA committee ended up creating a new set of categories which range from A to E, which is a little bit confusing because different terminology, we're using letters here. But to me, the most important difference in those categories is they had this category D, which really tries to identify patients who have what we would normally call intermediate high-risk pulmonary embolism. So patients with right heart strain, both biochemical markers that are elevated and evidence of right heart strain on imaging, and to tease apart from those patients who also seems to be deteriorating, who seems to be at the highest risk of deteriorating towards death. And I think that was a really important category to create because the more recent evidence around catheter therapies for severe pulmonary embolism really is going to be focused on that category D, the patients who are at risk of deterioration, who maybe have this normotensive shock. So they don't fulfill high-risk category because their blood pressure hasn't yet met those criteria, but they have other severity signs like raised lactate, high oxygen requirements, tachycardia. We could spend a lot of time talking about all the other categories, but to me, that's one of the cardinal differences is that they created category D.
Right.
And Elena, I'm sure will have some other thoughts.
Yes, thanks, Kerstin. And I agree that's an important category. patients that fall under category D. And really, I think what was important here was to try to help clinicians understand that the clinical picture of PE patients is constantly evolving and that they may start in one category, but then rapidly evolve into a more severe category. And I think that was the intent behind this, that what they have at diagnosis isn't necessarily where they're going to be 6, 12, or 24 hours later. And another important part about this is that they included the respiratory modifier, which is not something that was historically described in previous guidelines. But again, it is something that we often see where patients have worsening oxygen requirements despite being hemodynamically stable. And so it does add another layer of monitoring for patients. And so these are some added features that weren't previously described in other guidelines.
And I could talk about this for a long time, so you have to tell me when you've heard enough. But another subtle difference, which I've already noted really makes a positive difference, is the previous high-risk category. We used to say that a patient was high risk if their systolic blood pressure was persistently under 90 millimeters mercury, despite resuscitation. And what they did with the AHA guidelines is they turned high risk into category E, the most severe type, but they have two subcategories, so E1 and E2. And I think that's actually very important. E2 is the patient who's in cardiac arrest. And E1 is the patient who is hypotensive. And although in our minds, we always think, oh, the high-risk case, we treat all the same, there are likely some differences in the way we approach those patients. The category E2, for example, we may or may not know that they have pulmonary embolism. They may or may not have had it diagnosed yet. So it might be a bedside diagnosis or suspicion. That's one example of why they might be different. There are many other things. We've just done a research study looking at how physicians treat high-risk pulmonary embolism. And one of the things that came out was that sometimes they respect contraindications to thrombolysis in the category E1, but not category E2, not in the patient who's had a cardiac arrest. Sometimes some of those participants were telling us that they would thrombolyze despite there being traditional contraindications to use of systemic thrombolysis. So I think that was an important distinction to acknowledge that high-risk pulmonary embolism has many different morphologies. It's quite a spectrum in itself. And that as we gain more knowledge and more evidence, guidelines may end up making subtle differences in the approach to treatment of these two categories.
Beautiful clarification. Thank you both.
Okay. So the guidelines recommend PE response teams, or PERT, to improve timeliness of care. How does a PERT team improve the evaluation and management of acute PE?
That's a great question. And we don't really have any randomized evidence to tell us how and why PERT teams improve care. But we do have some accumulating evidence in terms of qualitative research and other survey research that suggests that, first of all, the average physician, say an emergency physician or internist, they may only ever see less than 5 cases of high-risk PE in their whole career. And when we look at intermediate high-risk PE, it may be 20 cases, maybe less, who knows? So it's very difficult to gain specific expertise or concentrated expertise in the art of managing those patients when you maybe only see one patient every so many years that falls into that category. And one of the things we find that even though in Canada we don't have many PERT teams, most hospitals in Canada don't have a PERT team. One of the things we're seeing is that actually physicians who have managed severe PE commonly reach out to others for help. So they're reaching out to people who they believe have the expertise to help guide the treatment. So in some ways, I think a PERT team makes sense because our physicians are already looking for that expertise. They're already looking for somebody who knows the right thing to do for each patient. And of course, we have guidelines, and those guidelines are clear. But every patient tells a different story, and every patient has a different collection of relative contraindications, different bleeding risks, and different baseline function and comorbidities. So I think the real benefit of a PERT team is bringing concentrated expertise in managing these cases that don't appear every day.
Right.
And if I could add to that, I think one of the other benefits to PERT is, as Kerstin mentioned, it's really intended to be a multidisciplinary group of experts that you have locally. And you may not have what a tertiary care center has in your community hospital, but you may have somebody who has some experience that you don't have. And so having that ability to communicate with others who share in the care of acute PE patients is really helpful and important. And it also helps with not only communication, but timeliness of decision making. Oftentimes, we find that people, when they're diagnosed with severe PE, there's hesitancy to initiate even the most basic of therapies like anticoagulation, because people are fearful that they're going to need an advanced therapy and that it may interfere with having an advanced therapy at some point in the future. So having that coordinated effort to ensure that timely care and decision making is in place with step A, B, and C, depending on clinical scenarios, is a really helpful initiative. And I do think that we're going to see more of these in Canada. We are seeing an enormous increase in PERT teams in the United States as well as across Europe. So I think this is going to be something that eventually comes to Canada as well.
Right. So this is a good segue to the next question. Practically in Emerge, and this may be for Kerstin, but also Lana, feel free to add. For patients in the emergency with acute PE, who can safely be discharged home and who should be hospitalized? And this may be a simple, but of course not a simple question.
Yes. Yeah. Thanks for the question. So usually around 30 to 50% of cases diagnosed with pulmonary embolism in the emergency department may be suitable to be discharged home. We have a couple of decision rules. We have the simplified PESI and we also have the HESTIA rule, which if you're somebody who likes to use decision rules and sit down and go through each point one by one, we know that it's safe. So we know that you can safely discharge somebody home if they're negative on either one of those rules. I would also say, though, that emergency physicians are super expert at knowing who is going to be safe to discharge home for treatment versus coming to hospital. And there are several items that don't even appear on the SPESI or HESTIA. So good example would be somebody with dementia, maybe who doesn't have close caregiving. Maybe they look after their medications. It's an early dementia. Are they going to be able to manage their apixaban, say, at home? Will they remember to take it? Sometimes their medications might be in a blister pack, but getting the pharmacy to put the apixaban into the blister pack that day is surprisingly harder than you think. So I think emergency physicians are pretty keyed into those sorts of risks. We also worry about falls risks, mobility risks, etc. So obviously your patient has to be stable and they have to be able to mobilize and manage without oxygen and be comfortable and safe at home. But they also have to be able to attend a follow-up appointment in the next few days. That can be challenging even for people who are vulnerably housed, getting them to appointments. So it's really, for me, in the emergency department, it's a case-by-case basis. But patients by the new AHA guidelines who are category A, which they call really asymptomatic pulmonary embolism, category B, so patients who have pulmonary embolism but no signs of severity, and possibly category C1 and maybe even C2. So maybe some patients who have long-standing right heart strain who have a normal troponin, say, we might consider sending home if they're stable and otherwise they look like they're coping well. But it's a case-by-case basis, and we're going to look at everything else, including the heart rate, the oxygen requirements, etc.
Wonderful.
Okay, so in patients who require parenteral therapy for acute PE, the guidelines recommend low molecular heparin over IV unfractionated heparin. So can you tell us some of the benefits of low molecular heparin over IV unfractionated heparin? And if low molecular heparin should be started prior to advanced therapies, such as systemic thrombolysis or catheter-directed therapies?
Great question. Thank you. So we did make that recommendation in the AHA-ACC guidelines to use low molecular weight heparin preferentially over IV unfractionated heparin. And this largely has to do with the more predictable PK/PD properties of low molecular weight heparins. As people who use unfractionated heparin infusions know, it can take sometimes up to 36 hours before achieving therapeutic levels of either PTT or anti-10As, whatever lab assay you're using to monitor. And so in patients with acute pulmonary embolism, that's too long to really achieve your therapeutic target. And so we do recommend that at least the first dose given be low molecular weight heparin. And anticoagulants should be given regardless of going for an intervention, whether it's catheter-based therapy or systemic thrombolysis. And so it is something that does need to be incorporated into treatment models. And again, going back to the PERT team, something that can be helpful to have as a first reminder that unless there's an absolute contraindication to anticoagulants, the first dose of anticoagulants should be given while you're discussing the patient or prior to even having that conversation.
Yeah, and I usually say when I'm teaching emergency physicians on treatment of pulmonary embolism is if you have that severe case of PE, the first thing you do before you think about reaching out to other people for help is you work out, can I give low molecular weight heparin? So, we're quickly going to check the platelet count. We're going to check they didn't have major bleeding in the last few days. And we get that in as quickly as we can. And then we work out next steps.
Right. Okay, so for those advanced therapies, could you help us understand which patients with acute PE should be considered for that type of therapy? And how do we decide among the different types of advanced therapies?
Great question. So I think the simplest way to look at it is what we would refer to as high-risk pulmonary embolism, category E. There is no change to the guidelines there. We say that patients who are high risk or category E should receive advanced therapy. That would be in addition to anticoagulation, which would be given immediately. It's a little bit trickier with the high-risk PE patient. For example, if they are hemodynamically unstable or in cardiac arrest, it's going to be very difficult to get them to the place where they might use catheter-directed therapy, because usually that's not in the resuscitation room in the emergency department or else on the ward in a ward bed. So for high-risk pulmonary embolism, often the go-to adjunctive therapy is systemic thrombolysis. And we all know there are two options for systemic thrombolysis. There's alteplase and tenecteplase. And in cardiac arrest, I always tell people if you have tenecteplase, give tenecteplase because it's a single push. We're not going to drip it in more slowly. You can just give it as a single push if you have it to hand. And of course, not all wards have it there. Alternatively, you would be giving alteplase. And again, dose of alteplase change depending which guideline you look at. If it's in cardiac arrest, you could say there's no harm in giving 100 milligrams. If it's a little old lady, you might want to give 50 milligrams. But I think the clear-cut thing is if you're high risk or category E, if the patient is in cardiac arrest or impending cardiac arrest, then they need an adjunctive therapy. And probably the most accessible therapy and fastest therapy to give in that situation is thrombolysis, systemic thrombolysis. And I'll let Lana can talk a little bit about maybe the category D patients.
Thanks, Kerstin. So I agree. It is some form of thrombolysis that is available in every hospital. Not all hospitals are going to have advanced catheter therapies available. And in patients in category E, they're unstable. They can't be transferred to another institution that has a catheter-based therapy. And so having some familiarity with contraindications to systemic thrombolysis is important, understanding different doses, as Kerstin mentioned. And I'm an advocate for knowing that you can start with a little bit and give more. And so I know many people are worried about bleeding risk with systemic thrombolysis. And so you don't always have to give the 100 milligrams of TPA. If that's what you have available, you can start with a smaller dose and give more depending on response. I think when it comes to catheter therapies, it really does depend on what you have available in your institution and expertise of the person who's doing the treatment. The interventions are nuanced. There are many different catheters available, and there are aspiration catheters that simply do mechanical thrombectomy. And then there are catheters that also give thrombolytic agents as well, so a more targeted thrombolysis approach. And how you choose one treatment modality over another, again, really is individual patient based and depends on proximal location of the clot. Not all clots are amenable to mechanical thrombectomy. They do certainly need to be in the proximal pulmonary arteries to be most effective. And so sometimes if you have clots that are a bit more distal, that may be where catheter-directed thrombolysis is going to be more favored. So I think it does depend on a number of patient-directed factors that guide whether or not thrombectomy or catheter-directed thrombolysis would be used.
And it'd be important to say that I think at this present time in Canada, I think most hospitals tend to have one option available to them. Sorry, most hospitals that offer catheter-directed therapies. So this is not something that we can make up a protocol for on the spot. So your patient's only going to go for catheter-directed therapy if your hospital has a pre-existing pathway to do so. So there already are the experts who have the catheters, who have the expertise to do the procedure. And that could be an interventional radiologist, it could be a cardiologist. That can vary site by site. And does it really matter? Probably not, as long as you have the one expert who offers that. People are diagnosed with pulmonary embolism day and night, and at weekends as well as during the week. So developing some sort of service where that can be offered 24/7 can take time. So it may be that your site has a protocol during certain hours and not during others. But those are things that have to be set up in advance, way before any patient ever comes along needing that service. And if your hospital doesn't have any protocol, then I would not suggest sending the patient to have catheter-directed therapy if there's no pre-existing protocol or pathway. And that would mean automatically that if you're going to give an advanced therapy, you would give systemic thrombolysis. I think the patients where the greatest nuance sits are those D patients where maybe their lactate is rising, their blood pressure is, in quotes, the normal range. I mean, it may be a little bit softish, but it still hasn't met the criteria for that drop in systolic of 40 millimeters of mercury or the blood pressure systolic under 90. And we have a lot of patients we treat for severe PE are elderly and comorbid. And in fact, it's actually probably more common amongst those patients, even though we think of cases of severe PE as being healthy young people with maybe fractures or something like that. It is more often people who have other comorbidity, and sometimes they have lung comorbidity. Sometimes they could have COPD or interstitial lung disease, and those might be patients who have no room for deterioration. They're maybe on maximum oxygen therapy, and we might be in the category D thinking of giving an advanced therapy to those patients if they're really at the end of the line for their oxygen therapy, if they have lung disease. There are other subtleties, patients who've had previous strokes, ischemic strokes. We know they have a slightly higher risk of intracranial bleeding with thrombolysis. So if it's somebody who's developing shock in category D, the lactate's rising, the heart rate's getting worse, oxygen requirements are increasing, but maybe they have a history of 2 or 3 strokes in the past, then if we had access to a catheter, those patients might benefit from catheter-directed therapy, because if they are using lytics, it'll be a lower dose, and they may not be using lytics if it's a mechanical extraction. Or if we don't have access to catheter therapies, we would be offering a low dose of thrombolysis. So it's the art of deciding which advanced therapy would be best for which patient in combination with what's actually available at your site. And we hope in the coming years that we're going to develop systems of care, but that's just a little bit further off from where we're at the moment in Canada.
Amazing.
Okay. So moving away from the higher risk PEs, patients often ask about flying after an acute PE. Can you tell us what the guidelines recommend for this?
Thanks. So this is a very common question that we get in clinical practice, and it's most concerning for patients that are away from home and diagnosed with a PE. And ultimately, their plan had been to get on a plane a few short days later and travel home. And there's not a lot of great data to support what to do in those settings. In general, what we recommend clinically in practice and what we've recommended in the AHA-ACC guidelines is that patients should wait up to 4 weeks to fly after acute PE diagnosis. And the rationale for that really does have to do with changes in oxygen concentrations when you're flying. So although airplanes are pressurized and that sort of thing, it's not the same oxygen concentration when you're flying at 30,000 feet as when you're on the ground at sea level. And so it does make a difference. So the recommendation of 4 weeks is certainly a guidance. There's no clear data to support it. There are some patients that may choose to fly sooner than that. And that, of course, is a risk that people are willing to accept. And I think it's important that people understand what could happen if they're flying, just that they may become hypoxic, short of breath, and they may need some supplemental oxygen, may lead to diverting the plane and landing in a different location. So there's lots of different scenarios that could happen. And I think the 4 weeks is a very conservative sort of suggestion for avoiding flying during that time period.
Okay, that's fair. So, what are the ongoing evidence gaps in the evaluation of management and management of PE? I assume there will be. So, could you highlight some of this?
Yeah, absolutely. I think I hit the nail on the head with describing how to select patients that may need advanced therapies. I think we need a lot more information about patient selection. I think we need a lot more information about which therapy is appropriate for which patient. And we're in a really exciting time for acute PE management. There are a number of studies that are ongoing that are these interventional catheter type studies that are evaluating catheters compared to anticoagulants, compared to systemic thrombolysis in different patient severity categories. And so this is going to be really changing how we manage PE patients in the future. And a lot of these studies are anticipated to be completed in the next year and a half to 2 years. And so this is really a space that we're going to keep monitoring. And this AHA-ACC guideline will be updated and adapted according to new information as it becomes available.
Yeah, to me, the biggest gap is the current evidence tells us that systemic thrombolysis causes more major bleeding than catheter therapy. But we don't know how that translates in terms of the individual patient and economic analyses. So a catheter-directed therapy is many-fold greater in cost to the Canadian healthcare system compared to systemic thrombolysis. And we also know that healthy people, younger people, are very unlikely to have major bleeding with thrombolysis. So I think once we have a little bit better granular detail around the exact risks and benefits for the different types of catheter therapies and the different doses of thrombolysis and also the different types, we don't even know how alteplase compares to tenecteplase, for example, then I think it's going to be very interesting to get some better economic analyses which are relevant to Canada to help Canada or the different provinces decide how are they going to roll these services out optimally. And if you're talking about regional hospitals where systemic thrombolysis is available, but those hospitals would need to transfer patients sometimes back for hours to get to a centre that would offer catheter-directed therapy, those are all unanswered questions. Does that extra risk of transfer, the extra cost of transfer, and of course the cost of the catheter in the first place, is that offset by the gains in health for the individual patient? And we really don't have those answers yet.
Right. So looks like there will be room for a couple of new research studies.
Yes.
Okay, great. So if there's one thing you hope clinicians remember from this paper when they return to practice tomorrow, what would it be?
For me, I think it would be, as I mentioned, that the PE patient is constantly evolving and that their clinical trajectory can change very quickly. So what you see at the time of diagnosis isn't always what you will see a couple of hours later. And so the idea that we need to continuously monitor patients is something that I think is important, and understanding the rationale for starting anticoagulation as first treatment, unless there's an absolute contraindication to it, and understanding that sometimes anticoagulation alone, most often actually anticoagulation alone, is all that patients will need, and they won't need any advanced therapies.
Yeah, and I would echo what Lana said. I think if there's one thing that physicians can remember from the new guidelines, it would be to give anticoagulation immediately. Now that catheter-directed therapies are becoming available, we've all heard anecdotally of cases where anticoagulation was withheld for severe cases of pulmonary embolism while people were calling around to see what would be the best treatment for this patient. And I think that actually inadvertent, well-meaning step can be the most damaging to patient health. So if physicians could remember just one thing, and that is to anticoagulate the patient And actually, the guidelines don't even, although there's almost no evidence, they even suggest anticoagulation before you diagnose the PE. So if somebody is a more severe case of PE, if you're ordering the CT scan, give them the dose of anticoagulation before the CT, because we can avoid death. I really believe that we can avoid deterioration and death if we give anticoagulation up front as soon as possible for the more severe cases of PE.
Excellent. Well, you've covered almost everything. I'm wondering if there's anything we haven't discussed that you would like to add.
I think I would add, as an emergency physician and somebody who loves D-dimer, that's a big focus of my research. The AHA guidelines give examples of different ways to test for pulmonary embolism. And we say, roughly speaking, in the outpatient setting, but that would encompass emergency department, but also patients who are just being admitted that day onto an internal medicine ward. So, and really the idea of those guidelines was simply to say to physicians, the standard of care is to use D-dimer. So it doesn't matter so much which protocol you use. It doesn't matter if you want to use years or you want to use age-adjusted D-dimer. The more important thing is use D-dimer.
I like that.
Yeah. So to me, that's a really important statement.
Well, Kerstin and Lana, for joining us today. It was a great discussion, a very detailed clinical guideline. So I'm sure our listeners will appreciate what you've highlighted today. And for our listeners, we'll include a link to the full publication in the episode notes. And if you enjoyed today's episode, be sure to subscribe so you don't miss future conversations covering the latest advances in thrombosis research and clinical practice. If you're looking for even more practical education, registration is now open for the 2026 CanVector Thrombosis Canada Research and Education Conference taking place November 6th and 7th in Montreal. The program features leading Canadian experts tackling challenging real-world thrombosis cases, interactive discussions, and the latest evidence to help inform clinical practice, including content related to these guidelines. Learn more and register at thrombosiscanada.ca/2026 conference. You'll also find our clinical guides, decision tools, patient resources, accredited education, and upcoming programs on our website. If you'd like to support our work in improving thrombosis care across Canada, please consider making a donation through our website. Thank you for listening, and we'll see you next time on CLOT Conversations. Take care.